Okay, today's lecture, I'm going to talk a little bit more about specifically the three diagnoses we're going to cover, which is the acute stress disorder, PTSD adjustment disorder, and then I do believe it's next week we cover the vicarious trauma. And then in more detail, I'm going to talk specifically about interventions and treatment goals, um, overall in general, and then also ones go over interventions and treatment goals that you guys can use to apply for your case study.
Okay, looking at the diagnostic overview, we just have the acute stress disorder, and PTSD both are an exposure to a traumatic incident, as outlined in the DSM. The acute stress disorder is anywhere from 3 days to 1 month after the trauma. PTSD is the symptoms lasting more than a month. Adjustment disorder does not include exposure to a traumatic event. Adjustment disorder is a response to a stressor. When we see the word maladaptive, that means that they are responding in an unhealthy way. It's maladaptive. It's impairing their ability to function at home, school, socially. They have poor coping skills. They're not responding well. The overall goal for all clients experiencing a trauma-related diagnosis and symptoms is you focus on symptoms that are causing distress, that are causing significant impairments in functioning. Now, what we are going to learn in the next couple of weeks is we're going to go through certain assessments and measures to help identify certain specific symptoms. But it's important that we focus on the symptoms that are causing the client significant distress. Clients might be overwhelmed with the amount of number of symptoms. And so a question that I often ask my clients is, which of these symptoms do you want to focus on? After I provide psychoeducation to help the clients understand that what they're experiencing is a normal response to an abnormal event. And I go through the diagnostic criteria with them, helping them to understand this is your body trying to process what you've experienced. And then I often ask them, what are the symptoms that they would like to work on that's causing them the most distress and causing them the most impairments in functioning that they want to work on. And then that's what I work on with them.
All right, now we're going to dive into the case study, Maria. One thing I want you to take notice of is when we go over Maria, listen to her symptoms. Clients are not going to come to you often and tell you their clinical symptoms through a diagnostic lens. They're going to tell you their symptoms through a story form. And so a goal is to be able to translate like layman's terms of what they're saying and being able to apply that into the clinical language so you're able to identify the symptoms that she's presenting. So let's go ahead and dive into Maria. Maria is a 34-year-old female who recently sought counseling following the sudden death of her mother 3 months ago. So here we see some key points. We see the death of her mother, and we see 3 months ago. So this could be grief and loss. It could be acute stress disorder. It could be anything. But let's go ahead and keep reading. Her mother was struck by a car and killed unexpectedly, an event Maria describes as unreal. Okay, so now we see 3 months ago the onset of a traumatic incident. It wasn't just the death of her mother, but it was how the mother died, which was traumatic. And then Maria describes it as unreal. So we could make, just by the trigger, we could possibly rule out PTSD. Now let's see if she has the symptoms of PTSD. Maria reports feeling frequently overwhelmed and having thoughts that she could not shut off related to the accident. So feelings of overwhelm could be anxious thoughts. It could be significant emotional distress. And then having thoughts she cannot shut off could be the intrusive thoughts. Now, as a reminder, the symptoms have to tie back to the traumatic event for it to be PTSD. She frequently replays images and imagined details of what may have happened to her mother. Even though she did not witness the event, she states that she becomes easily startled by loud noises, sirens, or unexpected movements, and feels constantly on edge. Maria also reports difficulty sleeping, sharing that she often lies awake thinking about her mother or worrying something bad might happen to other loved ones. When she does not fall asleep, she experiences restless sleep and frequent nightmares. So here we have the constant on edge hypervigilance, the easily startled hypervigilance, and then difficulty sleeping, and then the nightmares. So here we see she is reporting PTSD symptoms, looking at in more detail, in addition to the anxiety symptoms. Now we see the impairments in functioning. Difficulty concentrating at work, struggles to complete tasks she previously managed. She reports feeling emotionally exhausted and disconnected from others. Over the past several months, she's increasingly isolated herself from friends, declining invitations, and reports using food as a coping mechanism, noticing episodes of overwhelm.
So just a reminder, some common symptoms across all traumatic disorders are the intrusive thoughts and the constant rumination of the traumatic event. Mind you, clients don't want to be thinking about it. They want to shove it down. So it's intrusive. It comes whether they want it to come or not. The hyperarousal, the anxiety, the sleep disturbance, the nightmares, avoidance of the thinking about the incident, going around places where the incident occurred, isolation, difficulty concentrating, and then emotional dysregulation. Here are some evidence-based interventions. I'm going to go through each of these specifically in the next couple of slides, but here's some overall intervention: psychoeducation, CBT, cognitive behavioral therapy, relaxation, mindfulness training, emotional regulation training, sleep hygiene interventions, and social support enhancement. What I want to do for this particular class is give you an overview of interventions to do with clients, and more specifically for the case study, I want you to use interventions that you can tangibly apply in session. My goal is when you walk out of this class, you have a toolbox of active interventions that you can do in the therapy room. It's easy to look up interventions outside the therapy room to give to your clients, but when you're treating a client, you have 50 or 60 minutes. I want to give you actual tools. So for the case study, focus on interventions that you can actually do in real time with clients. All right, psychoeducation. This is probably the most important intervention that you can do with a client because it helps them to not feel crazy. It gives insight to what they're feeling and why. Clients may not have the knowledge or the ability to put words to what they're feeling, but their body is responding. Their body is doing things that they don't want it to do. And so they come in usually for symptom relief. So one of the main things you can do by helping the clients understand, this is your body trying to process the trauma. And so it normalizes the traumatic response. It explains the neurological effects of the trauma. It reduces shame and insight. Here's an example. What you're experiencing is a common nervous system response after the trauma. I do believe it was last week's lecture or video where I uploaded a video of the neurobiology of a trauma, how that brain responds and what happens. Just a summary is when you have experienced a traumatic event in the past, fast forward to real time, your brain doesn't know the difference between a perception or a reality of a threat. And so your body is going to alert you when it thinks there is a possible threat. It's a way your body is trying to protect you. It can protect you through flight, fight, or freeze. Even when there is no actual threat, it's the perception of a threat. Here's an example. Let's say you were on a run last year and you got bit by a snake. That's a traumatic event. Fast forward to a year later, you're on a run, you hear sounds in the bush. Your body is going to automatically jump and kick into gear to protect you from the potential of a threat. Now, let's say it's not an actual snake. Let's say it's just the wind causing the same rumbling. The amygdala, the part of your brain, is designed to alert your body for any potential danger. When we have that response, it decreases our ability to think rationally by 75 or 80%. Cortisol increases in our body, and that's our brain's way of being able to not overanalyze. Because if our brain was thinking rationally, we might not always have the amount of time that we need for survival. And so it decreases your ability to think rationally, and your body just kicks in. So that is what happens with PTSD. Is after a traumatic event, the brain is constantly scanning for potential threat. So when it feels or thinks there's a potential threat, it's going to have the same response. So that is the essence of PTSD and how the brain is being impacted. So being able to help the clients understand, it kind of normalizes some of their response. All right, here is probably one of the most utilized interventions to help a client through any type of trauma related incident, is teaching them relaxation and mindfulness. The reason why this is so important is because when you're having a traumatic response, your body thinks that it's in danger, and so you're going to have an increase in heart rate. You're going to have your cortisol is going to increase. You're going to feel on edge. Your body's going to think it's in danger. And so in addition to providing psychoeducation, you're helping the clients to identify the traumatic response, identify the trauma trigger, and teach their body that they're going to be okay and they're not in danger. I always practice these interventions with my clients in session. Just by providing the psychoeducation in itself isn't always enough, but by showing them in session how to do this intervention is key. Also, when you're talking about a traumatic incident and you see the client getting triggered, you don't always want it in the moment. Anytime you see some type of hyperarousal or distress, we don't always want to stop it. We want to still allow the client to process and talk about the trauma, but we want to teach them this relaxation technique when it becomes overwhelming for the client. So a simple technique that I do is before I start talking about if a client wants to process the trauma, not in detail yet, just processing it, I say, let's create some type of plan by identifying, it's called the Symptom Unit of Distress, SUD scale. Symptom Unit of Distress, SUD scale. On a scale of 1 to 10, 10 being the highest state of arousal, 1 being the smallest, you tell me when you've gotten to a level that's too uncomfortable for you. And so as the client starts to talk, if I see that they're starting to get overwhelmed, a shortness of breath, I'll pause them and I'll say, what's your symptom unit of distress right now? What's your SUD scale? And they'll just do a quick check-in. This also helps them to be just aware of their body. They may say, I'm at a 6. And I was like, how is a 6 for you? They say, I'm actually okay with a 6. Then let's proceed. Or they say, I'm actually not okay with a 6. In the moment, I will teach them a real intervention to help them get to more of a baseline and to stable them. Once they're more stable, I say, do you want to proceed? If the client says yes, we go ahead. If they say no, then we don't. So this is part of gradual exposure and part of helping them to process the trauma. So here's some examples of relaxation techniques and mindfulness. Teaching them oh my gosh, it's too early to read this. Diaphragmatic, where you are teaching the clients to hold their breath. Big inhale, hold, big exhale. Shortness of breath is going to cause more anxiety. Deep, where they're breathing through their stomach, they're breathing through the diaphragm, is key to releasing the cortisol and getting them back to baseline. Box breathing is picturing a box, breathe in, breathe out. Another mindfulness exercise, if I'm seeing a client in distress in session and they don't want to feel this anymore, I will do some grounding work and I have them put their feet on the floor and I will have them look around the room and I would have them count, how many windows do you see? How many tiles on the floor do you see? Also keeping your eyes open, count backwards from 100 to 0 by 6s. You cut in the alphabet backwards from Z to A. Another one is if they drove to your office, walk me through how you got from your house to here. What streets did you turn on? What off ramp did you take? Another one is what did you have for breakfast 2 days ago? What this does is this works part of the brain that helps the client to kind of get back to a baseline. Because when a client is feeling overwhelmed and distressed, their brain and their body thinks that they're in danger. So all this is doing is this is just bringing the client back to the here and the now, to the moment, so that they are realizing that they're not currently in danger. By teaching the client these interventions in session, I'm helping them to practice and give repetition. And so when they are experiencing distressing events out the therapy room, they have the tools that they need. Now, something I also tell clients is sometimes this intervention might work and sometimes it won't. So let's kind of build up your toolbox so that way when you're not in therapy and you're experiencing a trauma reaction, you can use a couple different ones to see what works. But the goal is to increase the window of tolerance to the distressing trauma response. Once you're able to increase the tolerance, then usually the feeling and the trauma response goes away. It's not that we want to shove it down, is we want to learn how to recognize it, realize what's happening, and regulate our nervous system, being able to cope with it, recognizing, oh, this is what's happening. My body's trying to tell me that I'm not safe. Breathe through it. I am safe right now. And then for sleeping, the same thing is I'll teach clients in session some relaxation techniques when they're becoming escalated before bed. There's this client that I'm working with. She's the one that experienced a couple different traumatic events in her childhood and in college. One of them is she was in an abusive relationship for a couple years and she was physically attacked by her abuser. One incident she remembers is when he put his hands on her neck and was choking her, what she described as a very long period of time. And she had very, I would say, not the strong, but she had physical signs on her neck where he put his neck around her and she had this huge red mark. That was a traumatic incident. So fast forward a couple of years before she went to bed, this memory popped up in her head and it was difficulty for her to sleep. And we tried a couple different mindfulness exercises in session. And the one that she reported helped her the most is for her to say the Lord's Prayer over and over and over again until she fell asleep. Another technique that I give clients is for them to download an app like the Calm app or some type of relaxation, meditation, video, something to help the part of their brain recognize that they're not currently in trauma, currently in danger, kind of helps them to cope. All right, in addition to the relaxation and mindfulness exercise is cognitive processing therapy. This is basically cognitive behavioral therapy, but what we're doing is we're processing the distortions around the trauma. Dr. van der Kolk says it's not sometimes the traumatic event in itself that causes us distress, but it's the meaning we create from the traumatic event that causes us distress. Those are identified as stuck points. There is a cognitive processing therapy manual. It does require certification to use, but there are elements that you can use without being certified. And one of them is the helping the client to identify stuck points. And I do believe I uploaded stuck points in Moodle on a separate sheet. So you can take a look at that. But here's an example of a stuck point. Something bad's going to happen to everyone I love. It is my fault the incident happened. I should have stopped them. I should have known better. I must be in control at all times to keep myself safe. If I'm not in control, something bad's going to happen. Those cognitive distortions, those stuck points, keep the brain and the body for a constant state of alert. This is one client I'm working with who was sexually assaulted in college. And one stuck point she has is, I must be in control of everything around me at all times or something bad's going to happen. And that was causing her to live in a constant state of hyperarousal. And once we were able to identify that stuck point and give her an alternative way to think, then she was able to not be constantly anxious, being able to learn to let go, that it's going to be okay if something bad does happen. When it does, if it does, then she'll be able to process and handle it when it happens. So challenge distorted beliefs, address shame, guilt, trust. I was working with a client, and when he was, I think it was around 10, his older neighbor, older cousin, sexually molested him. And because his body responded, because he got an erection, he thought it was his fault or he wanted it to happen. And so part of cognitive processing therapy, by addressing the distortions, you're helping the clients to see these are negative beliefs that are not helping them. They're not helpful. And so helping the client to understand your body is going to respond because your body is created to respond. That doesn't mean that you wanted the sexual assault to happen. So going maybe back to Maria's example, a way we can use cognitive processing therapy is encouraging statements such as when she has memories about her mom in the car accident, I'm remembering the loss, but I'm safe right now. I do want to make sure that we don't challenge distortions too fast, too soon. We do want to use a lot of empathy. If we challenge distortions too soon, clients may feel invalidated. So we want to provide empathy, attunement, psychoeducation, and say something like, yeah, that is a common thing to believe. That makes sense to me, why you would believe that. I hear, I see, makes sense that you would form this belief. You had no one else helping you through this. You were left on your own. So of course your mind had to figure out what was happening and why. So of course your mind developed this belief system. And I want to gently see if we could come up with another possibility, if there's another way that we can think it that might be more beneficial to you. So whenever I challenge a distortion, I want to make sure, guys, that we do it with tons of grace, empathy, unconditional positive regard. We want to still make the client feel seen and heard while we gently challenge their distortions. Now, in some cases, you will be doing a trauma narrative. A trauma narrative is talking about their traumatic story in detail. Now, if the traumatic incident just happened, it is appropriate to talk about the traumatic incident if the client wants to. It's very super important that we never, ever pressure or push a client to talk about their trauma when they're not ready. Here's an example. I was working with a client and she reported talking about her traumatic incident to a therapist many years ago. The traumatic incident happened, I think, when she was 18. Fast forward, she was 20. And first session, the therapist had her do a trauma narrative. It re-traumatized the client so much so that she did not want to talk about the traumatic incident at all. And so one thing that's important to do is you always put the client in the driver's seat. They have full control. Because when you think about it, when they've experienced a traumatic incident, that was outside their control. So we want to give the clients as much control as possible so that way they feel safe in the therapy room. And then whenever I do that trauma narrative, it's usually at the near end of treatment, where I've done a lot of psychoeducation, coping skills, gradual exposure, and the client knows we're leading up to this. The client's fully aware that this is the session we're going to talk about the trauma in detail. And so I have their buy-in, they're okay with it. They've developed enough coping skills to be able to tolerate the distress. And even in talking about the trauma narrative, I always give them the pause button, always. There was one client I was working with that we were building up to the trauma narrative. And the session came and we started to process the trauma with her dad, and she stopped. She's like, I'm not ready yet. And I was like, that's totally fine. So then we paused and we did some more somatic work, some grounding exercises, and got the client back to a baseline. And then we continued working on gradual exposure. But when the client is ready to talk about the trauma narrative, my encouragement is to never do it unless you get approval from a supervisor or somebody that has experience working with trauma to make sure that the client is ready. Because you all will be working under a supervisor's license. It's important when you're dealing with someone with significant trauma to always run your cases by them, so they can help you through it. But if your client is ready to talk about trauma narrative, is that you talk about the traumatic incident in such great detail that it goes from inside to outside. It no longer is stuck in, it goes out. And by talking about the traumatic incident in such detail, then the client learns to become desensitized to it. They no longer feel overwhelmed by it. They're able to get it out of their system. This is a very effective way. Now, you don't always have to do a trauma narrative. I worked with many clients who we didn't do a trauma narrative. We just processed the distortions they felt around the trauma. That is also effective. How do you know? A good question, or a frequent question I get, is how do I know what to do when I'm treating trauma? The answer is, are you seeing a decrease in symptom distress? Are you seeing an improvement in functioning from the client's perspective? The client tells you they're doing better. The client tells you that their PTSD symptoms have significantly decreased, their coping skills have increased, then you know you're doing effective work. All right, another intervention is gradual exposure. Gradual exposure is when you safely process aspects of the trauma memories, and you start with a lower level of distress. The goal for this is it increases the distress tolerance, it reduces the avoidance behavior. Example I have is there's this client I was working with, and her trauma was around her dad. And whenever we would talk about incidences that were bugging her, and we process overwhelming feelings, instead of saying talked about the trauma with her dad, we would put her dad's trauma in a box. What I mean by that is I would say, what's coming up for you right now? And she's like, memories of my dad. And I'll say, let's put the memories of your dad in a box and put it in the room. That's so then when we were processing and talking, instead of saying, yeah, when the rape happened, she said, when the incident with my dad happened. And then gradual exposure is eventually saying when the rape with my dad happened. Another way to do gradual exposure when I'm working with kids is I name what happened. What we don't want to do is we don't want to give nicknames to abuse or body parts, because that increases shame. So we don't have to talk about details and go into detail, but we want to name what happened. So working with a kid whose uncle molested her, and so the kid might say when he did a bad thing, and I'll say, you mean when he touched you? and the client will say, when he touched my private parts, when he touched your vagina. That's part of gradual exposure, and what that does is that helps the client to talk, to get out of what happened to them. It reduces shame, and by actually naming what happened. Like I said, it's very important we don't go into detail, but that's the way to do gradual exposure, is to using proper names. Another example relating to Maria, or case study, might be, today your goal is not to feel perfectly calm. Your goal is to stay present long enough for your body to learn that hearing traffic does not mean another tragedy is happening. So for Maria, one of her symptoms is hypervigilant, hyperarousal around traffic sounds. And so a goal is for her to hear the traffic sound, recognize her body is going to have a traumatic response, a startle response, and in the moment for her to recognize this is what's happening, do some deep breathing, mindfulness, grounding techniques for her body to learn a traffic incident, or even a horn or a traffic sound, doesn't mean another tragedy is going to happen. Another one is, let's just spend 1 or 2 minutes talking about what comes up for you right now when you think about the phone call you received. And then, so it is about increasing awareness, slowing down, recognize the client to recognize this is what's happening in my body. My body is trying to process the trauma. My body remembers the trauma. My mind remembers the trauma. And then increase the window of tolerance to that, and slowly it passes away. Because the truth is, no feelings are final. And one thing I hear very often working with clients with trauma is the reason why they want to avoid it is because they think if I allow myself to feel this feeling or recognize it, it is going to swallow me whole and I'm going to literally die or be so overcome with the feelings I'm not going to be able to manage it. And so we're just helping them to recognize no feeling is final and that this feeling too shall pass. Okay, we're not going to go into too much detail about EMDR because this does require a certain level of certification and training that as trainees right now you are not trained to do, but a very common and popular intervention is EMDR, which uses bilateral stimulation, and it helps the client to process the traumatic event by being able to process the traumatic event, by being able to recognize their traumatic response and being able to bridge the two together so that way it reduces the emotional distress. There are some times, I know I have been trained in EMDR, but I haven't gone through the whole process yet. But there are times when talk therapy and the work that I've done isn't enough that I will refer out to a specialist for EMDR. I've received EMDR. It's absolutely wonderful. It's fantastic. And the research and literature is pretty strong when it's used appropriately. Part of what happens, I think, is if somebody tries to use EMDR and they're not trained, they can actually cause a lot more damage and harm. Like this client that I was seeing, she said her therapist did EMDR with her first session, which you never do. EMDR, the actual processing is one of the last steps. A lot of the work in EMDR is being able to gradually expose the client, increase their coping skills. And so don't include this in your case study because I want you to use actual interventions you can use in session. But just for your knowledge, if you're interested in treating trauma after graduation, I recommend looking into EMDR training. Okay, so the overall treatment goals for clients is to reduce traumatic related stress. How do you know what that is? Go over the symptoms with the clients. Ask the clients to show you which ones they want to work on and reduce those symptoms. For the case study, that's going to be your treatment goals. And the client obviously can't talk because it's a case study, but you could say, in a treatment goal is to ask the client which symptoms are causing her distress, for example, and then list them. Say, I want to reduce the hypervigilance, reduce the flashbacks, reduce the nightmares, increase distress around this trigger. So be as detailed as possible. We want to reduce the traumatic events. We want to increase their impairments. We want to increase their ability to stay connected with others, and be able to concentrate, and able to work, increase window tolerance. Overall, develop healthy coping skills. We want to decrease unhealthy coping skills by replacing with healthy coping skills. Unhealthy coping skills would be drinking, binge eating, numbing out. Healthy coping skills is being able to actually cope with the distress, not numb or avoid the distress. Decrease avoidance behaviors and improve sleep and daily functioning. For the case study, do not put these general goals. Be very specific as it applies to the case study. All right, overall clinical interventions to do with clients. Overall, the most important is to establish a very supportive therapeutic alliance. I can't tell you how essential this is when you're treating trauma, because clients have a huge sense of mistrust, a loss of control. Giving them control is essential. A lot of empathy, a lot of warmth, a lot of attunement. Without this foundational clinical intervention, without that strong therapeutic alliance, the work that you're going to be doing is not going to be as effective. And so that's the most important. And then you also want to assess the severity of the symptoms. So when we look at diagnosis, it's onset, duration, frequency, intensity. And then we will, like I said, next week, look at some of the different measures and assessments that we use to assess the severity. of the symptoms, but when I first have a client that has trauma, I want to see how much distress they're in. Because if a client is in a severe distress, my focus is just on stabilization, just on getting them coping skills, getting them stabilized. That's my very first goal. And then overall, as you teach grounding skills, coping skills, we want to restructure the maladaptive cognitions. This is the distortions. And then we want to monitor sleep. How we monitor sleep is by teaching them grounding, relaxation exercises, and techniques before bed. Those are overall clinical interventions to do. All right, some interventions that are unique to the adjustment disorder is not necessarily processing a trauma, but being able to improve how they're adapting to this distress. So we are increasing their window of tolerance to the distress, to the overwhelm feeling that they have. We also want to increase resiliency and flexibility, being able to help them really learn to bounce back, grow from the distressing event. Now, talking about kids for a second, there is a saying that kids are naturally resistant. Kids are naturally resilient, and that's not true. Resiliency is taught. It's something that is cultivated in them by the adults and safe people around them. Most of the time, we think that kids are not able to handle distress. But the truth is, it happens. Bad things happen, hard things happen, deaths happen. And so by helping a client and kids specifically learn how to cope with hard things improves resilience. One way that we do that is when something hard happens with a kid, being a safe adult for them to process, to talk about it, to work through. And so that's how one way that we help to learn resiliency is to help clients work through, talk through, feel through hard things when they happen. By helping clients talk about hard things as soon as they happen, that helps them to work through it, move through it, versus just shutting it down. When you shut it down, and that's when it gets stuck in your system. That's when we develop disorders and more pathological maladaptive coping skills. So as soon as it happens, being able to help a kid and a client talk and walk through what happened helps to build resiliency. With acute stress disorder, how it's different than PTSD is you still want to do some of the same interventions, but we're preventing a progression to PTSD. We're still helping them to provide psychoeducation. We are helping to regulate their nervous system, increase coping skills because the stressor just happened. And so you're giving them the exact same tools, but more immediate. And so we're preventing PTSD. We're helping them to learn this is my body's response. This is the normal trauma response. This is my trauma trigger. Learning how to cope with it when the stressor just happened. And that's going to hopefully prevent the progression to PTSD. And so for PTSD, the focus is a little bit more unique, and we might spend a lot more time in the rebuilding safety and trust. We might spend more time in increasing coping skills, a lot more time in gradual exposure, because it's been a while since the traumatic incident happened. It's more stuck in the body. So this client, the goal is to process the unresolved trauma. When the trauma just happened, we want to help the client to process it. When it's PTSD, it's unresolved, it's stuck. And so the unique goal of PTSD, the focus is it's unresolved, it's stuck. And we want to help them through it, but this process might take longer because it is so stuck in their system. All right, so for the case study, we're not going to do these discussion questions today. But for the case study, going back to the instructions, I want you to read the case study, point out the symptoms that you're seeing that are the trauma symptoms, whatever the diagnosis you're giving the client. And remember, it's only going to be a adjustment disorder, PTSD, or acute stress disorder for now. I want you to pick those out to help you with your diagnostic criteria. Then I want you to focus on those specific symptoms, and I want those to be your treatment goals, either to reduce or increase those specific symptoms, behaviors, using specific interventions that we discussed. The case study assignment is not here, so you have to reference it. It is important that you follow the rubrics and that you are as specific as possible. Like I said, I want to give you guys actual interventions to use in the therapy room. For the case study, as always, email me if you have any questions. I'm always here to support you all. All right. See y'all soon.